Good evening, everybody, and welcome. I see my brother in the audience there. Hello, brother. I'm Roger Kirby. I'm the president of the Royal Society of Medicine for another 5 weeks, and then I'm going to hand over to Jill there, who is desperate to take over. And Jill, it's only another 6 weeks to go, and then you take over the reins. So it's so nice to have you here. We've got a really special lecture coming. So I don't normally read the intro. I like to kind of ad-lib, but there's so much to say that I thought I would read it tonight. So Edwin Stevens, CBE, the father of Howard, in the front row there, was a Welsh inventor who designed the world's first wearable hearing aid. He was also a philanthropist, becoming a major benefactor to the Royal Society of Medicine, well done, and to Jesus College, Oxford, where he studied between 1927 and 1929. He was born in Monmouthshire, and he started working in the Radio Corporation of America. And then as a salesman for the manufacture of electrical hearing aids, he considered that the products he was selling were just not good enough. So he set up his own company, entrepreneur and innovator, which is something we're very interested in here, to make better hearing aids. So he designed the world's first wearable electronic hearing aid. The microphone went on the label. The amplifier went in the jacket pocket, just like mine tonight, and the earphone was small enough not to need a headband. Eventually, as the technology improved, Stevens created a hearing aid that was small enough to fit completely in the ear. His hearing aids were used by no less than Sir Winston Churchill, who was Stevens' personal client. He also had a comprehensive collection of aids to hearing spanning 400 years. That must have been interesting. He was married to Kathleen James, had 3 sons, one of whom is Dr. Howard Stevens in the front row with his charming partner, Desiree. And we're hoping that David, his brother, is coming, although there was I got a text message that he was held up. So Dr. Edwin Stevens' generous bequest has funded an annual public lecture here at the RSM every year since 1970. Can we have that slide here? Yeah. So you'll see from 1970, it's really who's who in medicine who've given this lecture. And if we go on beyond to the second slide, please. Second slide, please, or do I need to advance it? Oh, here we go. Yeah, so recently we had Ben Chalicum talking about robots in surgery, colleague of mine, James Larkin talking about immunotherapy for melanoma, game-changing, life-changing, life-saving therapy. And last year we had Matthew Taylor talking about the 75th anniversary of the NHS and the urgent need for a strategy. So tonight's speaker is Professor Kevin Fenton. There he is in the front row, who's worked at CBE, I should say. He's worked in a variety of public health roles across government and academia before joining the board of Public Health England. Before taking up the London Regional Director role, Kevin held a joint position as Strategic Director of Place and Wellbeing and Director of Public Health at the London Borough of Southwark, where he led the council's planning, regeneration, community engagement and public health portfolios, driving inclusion, regeneration, community development and health promotion. I mean, Kevin, you've done amazing things, and we're expecting an amazing lecture from you tonight. He's led the Public Health England's National Prevention Programme, including screening for cancer, health checks, public mental health, sexual and reproductive health, and a range of wellbeing programmes for infants, youths, adults, and older individuals, basically everything, really. Yeah. And he also established and led PHE's Health Equity Portfolio. So Kevin is a passionate advocate about leveraging the power of technology for patients. And really, since Apple have just launched its new iPhone today, which is geared up for artificial intelligence. It's a game changer, so they say. I mean, artificial intelligence is the name of the game, so I'm not surprised that we've got a lot of people here to listen to you. Kevin, over to you. We will have time for questions at the end, so think up some really difficult questions for Kevin, everybody. Good for you.
Thank you, Roger. Thank you, Roger, and good evening, everyone. First of all, let me just say thank you so much for braving the rain and the hail to get here this evening. I know that in an environment where many of our meetings are hybrid and it's much easier to be in our living rooms or in our bedrooms and listening to a lecture, the fact that you're here this evening matters. So thank you. This evening, I'm going to be speaking about the transformative power of AI, its impact on health care as it is emerging currently. But we're going to be asking a few questions about what is the power of AI for public health and what might we do to harness that power for good if we are going to solve some of society's big challenges and problems. To be able to do this lecture today is a real privilege for me. I've had a long interest in technology and how we apply technology to improve population health. I've done a lot of work on digital health, on mobile health, and now more recently I've been really examining and getting an understanding how we use AI, both in our day-to-day jobs, but also to leverage it to inform, empower, educate, and improve the lives of people. So I'm hoping to take you on a little bit of journey today. We're going to be looking at the data as we know it. We're going to be looking at some examples. We're going to be looking at principles for understanding how we use the technology. And I can't think of a better lecture to do this at. And I'd like to acknowledge the leadership of Arthur Stevens in reading his biography and understanding the legacy and impact that he's made on technology. This is both a fitting lecture and I hope one that Howard, Desiree, that you will enjoy as well. So I'll be covering a few things in the lecture this evening. First, just really reflecting on where we are with the health of the population today and recognizing that the emergence of AI isn't taking place within a vacuum. It's taking place within social, political, economic, and significant demographic and health changes as well. So if we are going to be leveraging the power of AI, we need to understand where the population's health is and where it is likely to go so that we can harness it effectively. We'll be looking at some of the ways in which AI is already making a difference in the health and care system. And I would argue that when you review the literature on AI and public health, you get lots about AI and clinical care, AI and medicine, which are an important part of our public health practice as well, because we are in the business of ensuring that health care systems are sustainable, high quality, and effective. But what we are not seeing as yet is AI's role in both educating, empowering, dealing with some of the issues that communities are facing, and their big challenges with bias, inequalities, the infrastructure which is required to leverage the power of AI, and that's missing so far. So we'll be examining some of that in the challenges, opportunities. And those of you who know me know I would not finish a lecture without talking about the role of leadership. And we're all leaders. So this is not about what policymakers will do. It's not about what the mayor will do. It's what all of us in the roles that we have, in the narratives that we share about the role of AI in public health and how important that is, that we'll have a chance to explore that tonight. So let's get started. These are really complex and challenging times for the public's health. And as a public health practitioner over the past 3 decades, saying that when you live in interesting times is both a blessing and a curse. These really feel as if they're difficult and complex times. In part because we're seeing significant changes which are occurring right in front of us. And I think it was Professor Sir Marmot who said that the reality of our health is dependent on the state of our society and the distribution of power and resources within it. And when you understand that health is not just a byproduct, but is one of an outcome of what's happening in society, it changes your views on how health is generated, how it's supported, and how it's maintained. Now, there are big changes happening within our society, largely driven initially by demographic shifts, which are resulting in an aging population, an age differential in where the population is distributed, and therefore the health conditions that the populations will experience. For the demographers in the rooms, and those of you who love data, these are population pyramids, and it really shows just how the structure of the UK population has changed over the past 100 years. In 1911, clearly we had lots of people who were much younger at the base of the pyramid, and a much smaller proportion of older individuals, people who lived beyond 70 and 80 years. As you move to the 1950s, you can see the impact of the First and Second World Wars and the population shifts which occurred at that time. But the real changes that you're seeing are more recent, where the population pyramid has become a population column. In other words, we're not seeing the large proportions in the population of young people, of youth, which are important both for the age dependency ratios which are occurring in the country, the proportion of older people to younger people in society. And that means that that will have impacts on the economic sustainability, your pensions, the health conditions that you're grappling with, the services that you need. And it is also having a huge impact as well on the costs to the health and care system as we're dealing with an aging population with multiple morbidities, multiple clinical conditions that need to be managed. There are other shifts which are occurring as well. Life expectancy, after decades of increasing year on year in the United Kingdom, is now stalling. And in some parts of the country, especially in more socially and economic disadvantaged parts of the country, it's beginning to fall. And we're seeing this pattern both for men and women in the United Kingdom. And that is a factor which has occurred with the pandemic, but we've not yet recovered from. On the right-hand side of this chart, you can see the trends in life expectancy by level of deprivation within society, with more affluent parts of the country being in the higher lines in the blues and greens, whereas those living in more economically disadvantaged parts, you can see at the bottom of the trend lines. And you can see the plateauing which is occurring in life expectancy, but most importantly is the near 10-year gap that we see between the most affluent and most deprived parts of the country in life expectancy. What's also changing, in addition to the demography as well as life expectancy, is healthy life expectancy. So how long can you expect to live without a long-term limiting condition? And how does that differ between more affluent or more deprived parts of the country? So again, on the left-hand side of this chart, you can see that if you're living in some of the most deprived parts of the country, you can expect to live about 51.9 years in good health. Now, I'm not sure how many of you are over 52 years here, but can you imagine having to have your first or second long-term condition much earlier in your life? And we know that with their life expectancy, they can expect to live about 20.4 years in poor health. Compare that with people who are in more affluent parts of the country. They can expect to live in nearly 70.7 years in good health, with about 15.6 years in poor health. So you expect to live longer in good health and a shorter, more contracted period of poor health. And what's driving this poor health? On the right-hand side of the graph, we look on the chart, we look at some of the conditions which are driving poor health or driving morbidity within our society. And at the top of that list are musculoskeletal conditions such as lower back pain, but we also have mental health conditions, anxiety, disorders, headaches, and of course we have the chronic conditions like diabetes, hypertension as well. So those chronic diseases are not randomly distributed in the population. Those chronic diseases on an aging population are causing significant challenges within our society. And another key challenge that we're seeing as a result of these changes is the worsening or exacerbation of health inequalities. And we now know that not only did COVID-19 shine a light on existing inequalities, but it certainly exacerbated quite a number of these. These data are from the NHS Race and Health Observatory, and they highlight some of the significant differences that we see between racial and ethnic groups when it comes to health outcomes in the United Kingdom. Many of these differences are persistent, they're pervasive, and they're getting worse, exacerbated by many of the social and economic changes and challenges which I've described. So I've started here because to ground the conversation today, if we're talking about the transformative power of AI, we need to know what the health situation is. We also need to understand that public health as a profession and as a practice is changing as well. Because faced with the data that I've shared and faced with the challenges that we have, we need a new kind of leadership. A leadership that really is abandoning some of the simplistic narratives about what causes health, what causes these inequalities, and begins to think about the multiple drivers which are acting simultaneously to result in the outcomes that we're seeing. We need to collaborate across sectors because none of us working individually have the solutions to the complexity of the challenges that we're faced with. We need, therefore, to think more critically. Systems work, systems leadership, embracing equity and justice must be part of the narrative that we bring to our work when it comes to improving health. And of course, this requires leading visibly and with courage and compassion as well. Because as you look at the data, these are the lives and the stories of your neighbors, of your colleagues, of your family members, and that compassion has to be part of how we lead for health moving forward. And as COVID has taught us, it has to be done with trust, in partnership with communities as well. And there are two other factors which I think are really critical. First is embracing the ethical and the appropriate and inclusive use of technology. And that brings us to the lecture today, because it's within this new way of leading for public health that AI finds its home, that AI finds the possibility of doing things differently and getting different outcomes. So let's move on now to begin to explore how AI is already beginning to have an impact on health and care and what it might mean for public health. And I say this because we often think of public health as separate to health and care systems, but let me just dispel that myth today. As a public health practitioner, I am as interested in what happens in the NHS as I am in what happens in communities across the city. Health care is a small part of what drives our well-being and health, but it is an important part. And so therefore we need to understand how AI is having an influence in healthcare as well. Now, I know you're all here because you all have an interest in AI, so I'm not going to go back to how it's been derived and what it is. But again, it is the power of using technologies to have a vast array of methodologies that can enable us to do things differently at speed, using computer vision, natural language processing, and machine learning. And what it does is that it allows us to identify patterns much more rapidly at scale. It allows us to move from the individual to begin to think about predictive capabilities, and it allows us to manage much larger data sets than we could humanly do in a much faster period of time. And that, in a sense, is where the transformative power begins, but it isn't where it ends. We're beginning to see the role of AI in health and healthcare in a number of ways. In optimizing healthcare systems, for example, the ways in which hospitals are organizing the flows of patients, looking at efficiencies in how patients navigate hospital systems, how we allocate resources, how you do, through robotics, different procedures, and how you can gain efficiencies in that way. We can revolutionize the way we diagnose disease and the way we detect disease by looking at genetic data, which require large processing capabilities, by looking at the ways in which you can think about the data to think about personalized medical strategies and to tailor your diagnoses and your treatment based upon your findings from AI and genetic testing. Personalized medicine is another area that we're beginning to see and use AI technologies. Again, looking at how you can use routinely collected patient data to both improve the predictive capabilities that you have to diagnose and manage conditions, but also to predict the impact of medications and treatments for individual patients as well. We're seeing drug discovery and development being revolutionized by AI as well, really accelerating the pipeline for the development of drugs, analyzing complex molecular structures, and thinking about reducing the time that it takes to develop these new technologies. We saw the impact of this with the COVID pandemic. We're seeing it increasingly with new vaccines, new drug treatments as well. Many of you in the room working in the NHS are seeing the impact of AI on medical imaging and remote monitoring, really looking at algorithms that can manage large data sets, lots of information, giving us greater speed, greater precision, greater ability to detect anomalies, and therefore more accurate diagnoses. And the combination of using AI with humans gives you both speed, accuracy, as well as the ability to make much more informed patient decisions. And finally, in clinical practice, we're seeing the role of patient education and support. The chatbots, which we're used to having when we're paying our electricity bill or we're engaging with other sectors, are now finding their way within health and care systems, helping patients to navigate healthcare systems much more effectively. And a great example of this is new work which is being done by NHS 111 using natural language processing technology to help to understand how they can better navigate patients who are calling 111, routing them either to online resources to assist them with their clinical conditions, or triaging patients, depending on what they say, to the appropriate clinical care and clinical resources. And the pathway for this includes calling NHS 111, the natural language processing, listening to the caller, accessing the database, really recommending the appropriate pathway of care, and therefore having a huge impact on speed, on efficiency, on accuracy as well. And some of the early results of NLP in London are highlighted here. More than 2.5 million patients who've been rerouted to correct pathways using natural language processing, and more than 330 calls which have been channel shifted away to digital pathways, thereby freeing up the healthcare worker to do things differently. So NLP is just one example of how you can drive efficiency within your health and care system. And some of the key benefits are highlighted here. These are data from the NHS in London, really helping us to provide the right care at the right time, reducing NHS 111 call times, and leaving the clinical capability and capacity to focus on the areas where they can make the best difference. And again, a number of other successes which have been highlighted as well. Now, in essence, therefore, pulling this all together from our early experiences in clinical care, we begin to put these initial signals together to begin to think about what good might look like as we think about the future of AI in clinical care. Critically, we're moving from being able to describe patterns at the individual level to do so at the population level faster, and we're able to bring that to predictive care as well. So we're getting better at individual risk prediction and diagnosis, better at active case finding and surveillance. The potential to forecast population events and trajectories will improve clinical decision making, and hopefully in time to do a much better job of targeting our interventions and focusing resources where they can have the greatest impact. Now, if that is clinical care, what does it mean for the health of populations? How do we move beyond diagnosis, the MRI scans, CT scans, to begin thinking about some of the opportunities for individuals and communities? Well, in reviewing the literature and in our own experiences, we're beginning to see 5 major opportunities for AI and public health. And I'll be reflecting on some of these as we go through the lecture today. The first is doing what we call in public health the bread and butter of our practice. It really begins in having good data, characterizing disease, patterns of disease in the population, and understanding where to intervene with your effective interventions. So really revolutionizing disease surveillance and outbreak response, because we're able to manage data, large data sets more effectively. We're able to look at new data sources, for example, reports on searches online, reviewing newspaper reports in different languages. You increase your capability to obtain information for surveillance, thereby identifying patterns earlier and therefore intervening earlier. We can look at personalized health interventions. Again, if you're able to look at healthcare data more effectively, then you can identify people who may be at risk, to identify where to target those individuals in the population, how to intervene earlier. And the challenge that I mentioned earlier, where more people are living with multiple conditions and are developing them earlier in their life course, AI may be able to help us to get beyond the curve, to go ahead of the curve, to help to identify those at greatest risk. The concept of precision public health is entering the lexicon as well, and this is about identifying individuals at high risk of specific diseases based on factors such as their genetics and lifestyles, and again using AI to help us to target our interventions as well. So precision public health may well be another area. An area which I think we don't see a lot of in the literature as yet is how we use AI to empower individuals and communities. How do we ensure that this new technology isn't just in the hands of specialists, but how can we use the technology to educate, to empower, provide better health information, support people in their self-management, to help them to be far more proactive because they understand their individual risks and they understand what can be done to mitigate those risks as well. And fifth, an area which I think is again relatively unexplored, where public health practitioners and leaders have a lot of experience, is really looking at the ethical considerations which underpin the use of these technologies, not just in its clinical applications, but in its applications within the community as well. How are we thinking about building the capacity and capability of communities to leverage these technologies? What are we doing about ensuring that the logistics, the data, the resources, which are differentially going into the private sector and healthcare and clinical settings, are more evenly distributed so that we can all benefit from this? How do we ensure that some of the most vulnerable communities that are at greatest risk of poor outcomes are able to leverage these technologies in new ways? And how do we co-create this future with those communities? What are the ethics and the ways in which we can do that? So, we can look, therefore, at a number of new use cases which are emerging for AI and public health. And these are just data from the UK HSA, the UK Health Security Agency, about their early use and exploration of AI. And it's a recent publication from UK HSA where they're looking at AI for surveillance, really looking at open source models to process text, extracting key information from data sources to, again, improve your surveillance capability. They're using AI with their administrative functions to help them to look at large language models, to look at written evidence which is submitted for submissions, for example, for the COVID inquiry, to look at key themes, to begin to think about how you process large amounts of information more effectively. And of course, AI and data management as well, another key area where the use of large language models is being piloted in conjunction with the knowledge library services to begin thinking about extracting information in ways that can help them to move fast and make better decisions based on emerging evidence. And UK HSA has been thinking about core principles which should underpin the use of AI in its application in public health. And here are 6 key areas where we are beginning to see not only the UK Health Security Agency, but other public health agencies say that if we are going to leverage the power of AI, we need to be thinking about strategically, how do we prioritize this? We need to think about its appropriateness, the impact and benefits. We need to validate the models which are available and which are being used. We need to understand the risks of these new technologies, and of course, to think about the sustainability, affordability, and budget impact as well. Again, other organizations and agencies are beginning to develop their own policies and priorities for the use of AI. And in fact, in this publication from the Pan American Health Organization, which I know you won't be able to see at the back, but you will be able to see if you're online, and I will be able to share these slides out later. We're beginning to see disparately across the globe where AI is being used for public health. And again, similarly, it's the same technologies and tools of machine learning, natural language processing, natural language understanding, cognitive research, robotics, deep learning. All of these tools are being applied to various aspects of public health. But what is missing is what is the global approach to this. What is missing is what we do in public health, which is develop a strategy, look at the resources, understand the equity implications, understand the sustainability of this, and ensure that we're raising all ships at the same time. So at the moment, there are pockets of brilliance which we're seeing around the world, but can we do more to leverage this? So let's look at a few case studies to go a little bit further in the ways in which AI has been used and is being used in public health at this time. And the first case study is just looking at the use of AI during the COVID-19 pandemic, where we probably had, for many public health practitioners, our first introduction to the use of AI at a large scale and to see it being used in so many different ways. And again, as you can imagine, a lot of this was around the predictive analytics and the forecasting of infectious disease outbreaks. We certainly saw that being applied for factors such as the influenza prior to the pandemic and subsequently post-pandemic to be able to use different data sources to be able to help us to predict disease outbreaks and to predict the intensity and severity of diseases as well. As I said, COVID-19 really resulted in a shift in all of this, and really we've seen the use of AI in a number of ways throughout the COVID pandemic. Again, this table and the following one really highlights just the diverse ways in which AI made a significant difference and a leap forward for public health practice at that time. From diagnosis, surveillance, and contact tracing, as I've mentioned previously, dealing with misinformation. And looking at trends through searching online stories about what are some of the emerging challenges which were happening with the COVID pandemic. Automating COVID-19 screening, drug prediction, and drug formulation were some of the areas where we began to see the use of AI. AI-aided responses were also seen for COVID-19 severity, transmission prediction, pharmacovigilance, surveillance, as well as reliable diagnosis using infravision. And I'm going to be speaking a little bit about this as well. But what we see here is just how pervasive and the opportunities of using the technologies in COVID-19 and the sense that we could begin to do things significantly differently. And these are examples taken from different public health agencies around the world. I've already mentioned AI and its use in surveillance and some of the work that's being done by public health agencies on this. The benefit here is the ability to analyze large data sets a lot more quickly, to reduce errors within your data analysis, and to be able to use different data sources, integrating them to characterize disease patterns and to look for opportunities for intervention. At the CDC, they've been developing resources using AI to look at how you use data from a variety of sources, which include electronic health records, social media, travel data, and this is enabling CDC colleagues to begin thinking about identifying and tracking outbreaks almost in real time. And new subspecialties of public health, of infodemiology and infosurveillance, using AI and data mining technologies, are really allowing us to look at searching not just disease outcomes, but behaviors, communication patterns on social media, and publication trends. Again, getting earlier insights that can help us with our surveillance as well. So, some other examples from UK HSA. The UK HSA tuberculosis unit is also using AI, looking at how it can enhance the manual review of country of origin documentation to identify those from high-risk countries who are eligible for TB screening in the UK. And this is currently being trialled in the UK to test its performance and the quality that it could bring. Finally, the third case study that I want to touch on today is around AI and public health diagnostics, a really important part of what we do in public health, because so much of our data comes from diagnostic methods. And these diagnostic methods are often time-consuming. They often hinder because of data sharing protocols, the timeliness in which you're able to look at the data. And there must be, to help us to diagnose infections or conditions earlier, opportunities to strengthen that as well. So we're seeing how AI is, in fact, revolutionizing public health diagnostics, improving the speed, the precision, as well as helping with overall health outcomes. And we need now to begin thinking about how we truly leverage this as we think about our public health activities and our work. Machine learning algorithms are really important because they're the workhorse of AI and perhaps some of the areas where we're beginning to see it being used most commonly, whether this is about how you begin to analyze data sets on lab results, on medical images, and again, looking for pattern recognition and disease predictions as well. Now, by analyzing all of these large data sets, we're able to look at subtle patterns, and that's where we get an opportunity to intervene earlier and to be able to ensure that we are acting earlier to have that impact that we need. A really good example of this in terms of how we use AI for diagnostics and how this can truly revolutionize what we're able to do is Healthy.io. And Healthy.io is a home test kit and a mobile app which empowers patients to self-test at home with clinical grade results. And it can be used to diagnose patients with diabetes, high blood pressure, or other risk factors for chronic kidney disease. And this integrates both the diagnostic tests with the patient's electronic medical records. It provides real-time results to clinicians, which enables clinicians to get a better handle on their patients' needs. But through aggregating the data, you begin to get a better picture of what's needed in the community in terms of your public health responses and activities too. Thirdly, there's the MIA for breast cancer screening, which is another new technology which is looking at intelligence assessment in mammography. And as many of you are aware at the moment, mammography really requires the hands-on use of radiographers and radiologists to provide and to identify diagnoses, provide second opinions. This can be labor-intensive, it's time-intensive as well, and of course, results in delays to treatment, and of course, delays to women. We've found that MIA is using convoluted neural networks, using deep learning, and has been trained on millions of images, mammography images from multiple sites. And this is enabling the AI to help with both the initial diagnosis of problems on the AI, which can then be reviewed and prioritized by the radiologists for second screening and second opinion. So by introducing MI into the clinical diagnostic pathway, you're able to speed up the process, but also improve the quality as well. Now, just as I move towards the end of the lecture, we really wanted to reflect on some of the challenges and opportunities for AI and public health. And you can begin to see, as we've gone through the lecture, where many of the challenges are going to occur. We have many silos within silos which are occurring. Data are collected, curated in different parts of the system. We may not be able to share the data, leverage the data, and of course, those data remain in silos. So being able to unlock, share, and use those data become important. That then links to organizational capacity, capability issues and system issues which prevent the sharing of data, the collaboration on AI. And in the absence of a strategic approach to this, then we have no unified infrastructure or production capability for us to leverage both the power of the data analytic capabilities, but also to integrate that into organizational strategic priorities. The third challenge is that we're probably at an early phase of implementation of the technology, so that it tends to be focused quite a bit on academic achievement, one could argue, but the real-world value, the real-world implementation and impact, and driving and evaluating the use of AI to improve population health impact is still in its infancy. Now, many of these challenges which are emerging are not insurmountable, but it does require us to be honest about the risks. why they exist, and some of the mitigation measures. And here we can see a number of biases which are happening in medical AI based upon sex and gender, age differences, race, ethnicity, your geographic location, your socioeconomic conditions. Again, because of how and where the data are coming from, how and what AI tools are applied, and who's doing the analysis and the integration, and what strategic framework. Some of the most common causes of the AI biases that we're seeing now in clinical practice are biased information and imbalanced data sets, structural biases and discrimination I've mentioned before, disparities in access to quality equipment and digital technologies, and the lack of diversity and interdisciplinarity in development teams. Huge issues for us as we think about AI in clinical care, and these same biases are likely to exist in public health as well. Now, mitigation measures are being in place, and we're beginning to see more of these. And I think the conversation today will certainly help to move that forward. We need to be thinking about how we integrate systematic AI training into the training of healthcare professionals today and in the future, and how we train the AI itself with more balanced and representative data sets. We definitely need more interdisciplinary training and approaches to use of medical AI, and the integration of different voices, apart from the technical ones and perspectives, including social scientists and members of affected communities. And we definitely need to promote more diversity and inclusion in the field of medical AI. Now, the National Health Analysis and Assessment Division in an all hazards intelligence have also looked at some of the risks of AI for public health practice. And they conclude that there are 4 key areas where we need to be absolutely focused on as AI becomes introduced and the technology is introduced. I've already reflected on bias and health inequalities, the erosion of trust in the UK government and health bodies. Who has my data? How are my data being used? Is it being used in an ethical way? Health misinformation and health information, and how AI may be used, whether through avatars, dissemination of misinformation rapidly, poor use of data sets and data analyses, a real risk of misinformation on health, and of course, the malicious use of AI as a threat as well. So we know that there are many organizations and systems looking at some of the threats that we have. But I wanted to end by reflecting on equity and health inequalities as one of the areas where I'm particularly passionate about, but also very concerned about as well. And it was Martin Luther King who said that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And there's a real danger that with the introduction of AI, like many new technologies, we risk seeing a widening of health inequalities before we're able to narrow those inequalities if we're not developing the technologies mindfully. So the question I know many public health practitioners will be asking is AI a force for good, and can it be used to reduce inequalities? And how do we mitigate the risk of it widening those inequalities? And those inequalities, as you can imagine, come from a variety of areas, from reflecting the real-world patterns of health discrimination and health inequality. So the inequalities which exist in society then become translated into how we build, analyze, use the technologies, and we get biased and discriminatory results. They come from discriminatory data, because if there are sectors of the population who are not using services or who are not being engaged in the development of AI, their voices and experience won't be reflected in AI technologies. Biased AI design and deployment practices, which results in the lack of diversity, inclusivity, lack of community engagement, lack of even public health thinking in how these tools are being developed, and of course, application injustices as well. Who has access to AI technologies? How are they used? And how are they used for the benefit of individuals and societies? So, as before, we looked at 5 opportunities for AI and public health. I think there are 5 opportunities for AI and tackling inequalities. The first is how we use it to reduce biases in healthcare decisions, and really training AI algorithms in new ways, using some of the mitigation measures which I've mentioned before, to help to identify and remove unconscious bias that creeps into clinical decision making. And we know this occurs, right? We know it occurs where who gets pain medication, who gets intervened earlier, how do we begin to start patients on different clinical clinical regimens and treatments. Clinical care is rife with decision-making biases. Can we use AI to overcome this? Can we use AI to help to improve access to healthcare, especially in underserved areas? Because if you're able to characterize your populations and your communities, then you're in a better position to be able to target your interventions earlier using the power of AI. Can we use AI to tailor some of the interventions that we're working with? So we're really losing this concept of precision public health, but applying it to tackle those who are in greatest need and to work with communities in greatest need to adopt, to empower and to use those technologies and to help to close the gap. Can we use language translation and cultural awareness differently as well, especially in a diverse a city as we are in London, where hundreds of languages are spoken? Are there ways in which language processing and technologies can help to break down some of the barriers on health information, engagement in care, signposting different communities into the services that they need, and also helping to communicate with healthcare providers? And then finally, the use of AI to empower patients to manage their own health. There is a real danger that the self-care movement will leave many of our communities behind. Can we leapfrog some of this using the power of AI? I'm going to end now by just a quick reflection on leadership and the roles and responsibilities of leadership. And I said at the beginning that visible and courageous leadership has to be a part of what we do now. We have to embrace the technologies. Why? Because they're here. Why? Because if we don't, then decisions will be made about us, without us, and without the communities we're serving that will only have a detrimental impact in the medium and long term. I think that as we think about leadership, there are a few key factors and themes which are repeated within the literature. The fact that the technology demands that we have a different conversation with members of the public, or with industry, academia, supported by appropriate regulatory frameworks. We have to run towards this new technology and create the environments and the systems which allow us to tackle it in a more effective way. We need to build skills and talents in new ways, and ensuring that the skills and talents and the right skills for the jobs of the future are much more distributed among all communities, especially those who might be at risk, and ensuring that the talent that we're building is sustainable over time as well. We need leadership that helps us to tackle access to data, sharing of data, access to these new technologies, and creating the sort of fair, legal, and ethical space that can enable us to do this work and to scale it effectively for population health. We need leadership that supports adoption, partnerships, and regulations that really drive public-private sector partnerships, that really think about the positive use of AI, work on evaluation, and work on scaling for population health. And this has to be done between national and international partners as well. We can see the emergence of different national policies to how AI can and should be used, and we have a real opportunity here, I think, of a different kind of leadership that begins to help us on this international engagement. Now, bringing all this together, there are going to be a number of core principles for us as leaders, how we ensure that as we think about AI, we commit to it being community and person-centered, that we begin to think about equity in all its forms, that we think about grounding it in ethical principles and ensuring that this is done within a regulatory framework, that we are transparent in how we use AI, and we're transparent in how we feed and how we analyze and how we adopt the algorithms which are being developed, how we protect data and we create environments where we can both assure patients about privacy and confidentiality, but at the same time work towards sharing the data for the greater good. That we work with our academic partners not only on developing AI tools, but evaluating their real-world use and their population health impact as a key part of what we do. We've spoken about being open and shareable, non-discriminatory, and of course, ensuring that the human element in the design, implementation, evaluation, and engagement remains. So colleagues, this brings me to the end of the lecture today. What I want to do is to take us through a bit of a journey of talking about the state of health in our society today, the challenges that we face, the role of new technologies and how it's currently being applied in clinical care, but to think about some of the core principles of how public health are already beginning to use the technology, but what more we might achieve. I wanted to focus a bit more on inequalities because I'm really concerned, and perhaps that's one of my greatest concerns, that with all new technologies we're seeing that there's a real danger of these inequalities being widened at a time when we need to ensure that we're narrowing those inequalities. And finally, that we're clear about some of the principles which underpin our work and leadership in this space. Thank you.
Kevin, go and sit over there. Fantastic. Brilliant slides. I bet there's a load of work in putting that together. That is a lot of work to do that. So I like this bit. This is where I'm kind of Fiona Bruce and it's BBC question time. And I hope we're going to have some questions. We've got Zaka over there with, oops, my watch is making some funny noise. Zaka with a mic and yeah, we've got Angie on the other side. So I'm going to start with a question. We had a guy called Richard Susskind here just a couple of weeks ago giving a talk, and his prediction was that AI is going to put a lot of doctors out of work. So here we have the political parties saying, oh, we're going to hire another, 5,000 GPs, 20,000 urologists, et cetera, well, maybe not 20,000 urologists, but and more nurses, et cetera. But Richard says AI is going to put doctors and nurses out of work. And is that, where would you?
Richard, if I had a pound for every time I've heard that some new technology is going to put some profession out of a job, I'd probably be a rich man. I think the reality is that our professions will continue to evolve. They evolved when antibiotics were developed. They evolved when new diagnostic technologies have been developed. They continue to evolve, and I suspect this is exactly what will happen. I think the role of the physician and the nurse will change necessarily because we will become far more efficient at diagnosing, identifying problems, and so forth. But ultimately, medicine is about the human touch. It has always been about the human touch and connection, and I suspect that won't change, and that need will be there as well, even though it may be manifested in different ways.
Yeah.
So I'm up for the evolution. I'm not about putting people out of jobs just yet.
No. So, your chatbot will see you next. Could happen. So, hands up, anybody? Okay, we have a question there. It's a bit random who I'm going to. I see Nicola in the back there. You better have a question next.
Is this thing on? Can you hear me? Hi there. I'm Bash Bhattacharya. I'm a radiologist from North East London. Just a quick thing, because with the rollout of AI to public health, a lot depends upon people's access to digital resources, for example, devices, and actual access to, the internet as such. And that's something can be quite variable. For example, the actual security nature of a device changes. The internet changes, and the populations which you're concerned about, particularly North East London, have lower access to that. So in a similar way, people talk about universal basic income. Should there be a universal basic device and internet access? Otherwise, all we're really going to end up doing is having technologies which really are aimed at the well-off.
Yeah. I agree. It is clear that the internet and access to the internet is now becoming one of those basic necessities of life. And I'm saying this seriously because whether it is for your financial security, your records, getting a job, surviving, you need that access. And there's a real danger that as these digital tools and technologies become available, we will widen that digital divide and inequality. And that is why in many cities around the world, providing free internet access is being seen as not only a nice to do, but it is a part of economic sustainability and development of urban centers. And it's a big part of the urban infrastructure and urban health infrastructure that we need. As AI tools are developed, being mindful about how and where they're deployed and for what purposes becomes important. And that is why I said earlier, a lot of this is happening without strategic approaches to what we want to achieve, for whom, by when. And it feels at this point that we're in such an early phase, we're just allowing things to happen, and where they land, hopefully they land and there's no harm. And I think there's a real opportunity for us in public health to begin to say, let's bring some strategic approaches to this. So we're planning effectively to mitigate the digital divide. We're planning effectively to engage communities and educate communities. We're planning more effectively and mindfully to mitigate the harms while we advance the good. So you're absolutely right about the needs there.
And maybe the NHS is in a better position than, say, the American healthcare system with all its private practitioners. Maybe the NHS is in a better place to do that.
Well, hopefully. I think the NHS is under its own pressures. And I think, in an environment where, so much of what becomes the defining narrative is one of performance against targets, which are geared towards acute and emergent care, then the space for us to think strategically about prevention, early intervention, precision, public health, all of the things that we've mentioned earlier today about the potential benefits, we need to find the space to create that, Roger, because there's a real concern that actually what will drive AI will be the shiny photo opportunity uses of AI rather than tackling some of the real challenges that we have. And we need space and strategy to be able to do that.
Nicola, and then the person sitting next to her, and then Martin, I see, has got his hand up. We've got some time, another 15 minutes or so think of some questions, everybody. Nicola.
Thank you, Kevin. I'm Nicola Stingelin. I'm a data ethicist specializing in AI algorithms. Would you agree with the hypothesis that in order to make use of the possibilities of AI, we need to reclassify the legal regulatory environment of this big data, and we need urgently the public health specialists to lead this in seeing this kind of data as a public health good and a global public health good, and freeing ourselves with unnecessary obsessions with personal data, and we really need to be leading this to be able to have access to the necessary high quality data to make the uses possible?
Yes, I do think that that's a part of it. But we also have to be careful in public health about how we share and spread that narrative. Because one of the things we learned through COVID is that part of that sharing and that more equitable use of the data must be enabling individuals and communities to be part of shaping, of creating, of understanding that. We have seen too many examples of big data projects which come to ground because we haven't taken the public along with us. Too many examples where people whose data are not engaged in decision making and whose illnesses are driving the development and the technologies and the new tools are not the beneficiaries of the new technology. So how do we, as we create those regulatory environments, do so differently to what we've done before? That, I think, is also the public health challenge that we have. Doing the same things that we've done before won't get us different and better outcomes. And we really have a chance now to do this with AI differently, especially by our communities. And that is where I think the public health narrative in all of this becomes stronger, because yes, we can do great things for individual patients. We're in the business of doing great things for communities and society. And that's a difference that we should bring.
The man with the impressive beard and the microphone. Tell us who you are.
My name's Andrew Moran. I'm the President-elect of Medicine and Society here at the RSM.
Right.
And Kevin, we work together at Public Health England as well. My concern really is about bias in the data, and I'm happy that you raised it in the final few slides because you kept answering my questions. So I'm very concerned about not just about the protected characteristics, but just the difference, say, between urban and rural as well. And that the AI models are built on what happened in the past. So if people are excluded, what happens in the future, say homeless people, for example. So then the question I've come to at the end is, how do we know, as these things come into people's clinical flows, whether it is a good AI? And apologies that is vague, but when it comes up, how do we know that it is a good one and not a bad one?
This is where I think the UK HSA principles, which I shared in the table, are so helpful, because in order for you to come to some understanding that this is good or bad, we need transparency. What were the data that were involved in helping to create and inform the model? who developed the model, using what principles, and going along the entire development pathway and having that transparency to be able to see, well, what data are we receiving, how replicable it is, how valid and reliable the data are, and ensuring that we're testing it constantly as well. So I think there's something for me about not moving too fast, but moving deliberately, and setting up principles which can influence the way we're going to do work in this space. And which is why I wanted to just share and highlight some of the emerging thinking from UK HSA, because I thought that was really a fantastic strategic way to say, actually, yes, there's new technology, and here are ways in which we are going to do this in a much more deliberate way to help to mitigate the harms. Like you, I share your concerns about bias in the data. And when you look at the development pathway for AI, you see it's rife with biases across. And remember some of the early ChatGPT, Gemini, before it was Gemini, was Bard. Bard was pulled off the market because typing in simple search terms gave you images, gave you text, which really demonstrated that actually the tools weren't culturally competent, not even culturally sensitive, and the validity and reliability of information that it developed. And again, nobody knew what was behind the models. And so we're not able to understand how these things are generated. So transparency, working with partners, all the things that I mentioned in terms of mitigation actions are going to be necessary. But I don't know if we'll ever get to a stage where we can regulate good AI from bad AI, but I think transparency and the ways in which we create a regulatory framework will be key.
Martin McKee, whose tweets you may have seen.
Kevin and I know each other very well. In fact, he was my student many years ago. So Kevin, thanks, that was great. Somebody recently said on X, formerly Twitter, that I had hoped that artificial intelligence would take over my housework to give me more time for creative writing. In fact, I find it's taken over my creative writing to give me more time for housework. So given that, and given the UK is the most unequal country among the industrial ones in terms of the gap between the capital, London, and the rest of the country, by a country mile, in fact, and large parts of the country have already been devastated from the 1980s onwards by the collapse of manufacturing industry, from automation, among other things. Is anybody thinking through what the regional implications of all of this, given that we've had a complete failure of levelling up, as we know, thinking through the consequences in this, and who's thinking about what are the incentives for young people to invest in their own education when the jobs that they might have aspired to have might no longer be here?
Yeah, so great question, Martin. As you know, this is a pre-election period, so I'm going to answer your question using a sort of framework of the theory and the practice that we have at the moment. So, if we don't plan for this technology in a way that is both mindful in terms of how it's used, how it's deployed, how we want to apply it to solve society's problems, then its use, I fear, is going to be limited in its use cases and in the benefactors for the technology. And what you've just highlighted is the fact that there are significant societal needs which need solving. Some of it might be better policies, it might be economic investment. AI is not going to be the answer to everything. But my goodness, where AI can make a difference, we should be testing and evaluating just to understand how we apply the technology for that benefit. At the moment, I'm not sure that there is that strategic approach. I'm not sure there's a strategic approach that says, for this new technology, how does this link to our scientific strategy or business strategy or place-shaping strategies? It's not yet in that consciousness. And perhaps those of you who are public health practitioners in the room, this is where we begin to ask questions. We've done this with climate change, when lots of our clinical and other colleagues were not talking about the climate crisis and health. Public health was there saying, actually, here are considerations, this is what we need to be doing, and this is how we need to be thinking about this in a more holistic way. Might this be another opportunity for us to be in that space, to think about that integration? AI won't solve everything, but it can have a significant impact in a few areas, and we need to understand them quickly. So.
Good answer. Jill.
Hi there, Kevin.
Hi.
Great lecture, and that inequalities question is the challenging one, I think, isn't it? Because the most likely scenario is probably the inequalities get worse because it's, as always, the affluent, the informed, the middle classes that benefit, and inequalities get worse. So to avoid that, I can only see that we need to put resource to prevent that happening. Resource to improve access to new technologies, resource to put into prevention strategies, resource to treat people that are picked up through AI. And is there that money available? Do we need to do the sacking of lots of doctors, as Roger was suggesting, or is there another route? What would you say to an incoming government?
So I'd say what I said to government when we're in the middle of the pandemic and we're thinking about how do we mitigate the impact of COVID on Black and minority communities. And one of the recommendations in the early Public Health England report was that we should design our programs and our interventions through the lens of equity. Too often we do programs and then we think of the health inequalities as an afterthought or later, by which time things have already got worse. And Jill, there are some great examples where when you put an equity lens on how you design and develop a program, you can mitigate inequalities. Those of you in the room who know the NHS Health Check program, it's a program where we invite people aged 40 to 70 years, 40 to 65 years, to come in for a health check. And you're able to both speak to the physician, have a battery of tests, be examined. And the idea is to look for early signals of your non-communicable disease, your chronic diseases. You're diagnosed with your hypertension, diabetes earlier. In London, we have been looking at two things. One, making the health check digital. And second, using an equity lens to deliver the health check program. And what does that mean? Rather than having it just be a universal program, we really work with the areas where the data says that we have highest prevalence of disease, the worst inequalities, and we need to do engagement with communities. In many boroughs, through that equity lens, we're not only seeing the highest uptake of the NHS Health Check program in the country, in London currently, but we're also seeing a reverse inequality occurring, where actually the uptake of the NHS program is highest in some of our socially and economically disadvantaged communities compared to the more affluent. Now, it would make sense because the more affluent ones are already seeing their GPs, probably having private healthcare, etc. But how amazing it is to see in this day and age a reverse trend where in some of our most deprived parts of the city, the NHS Health Check uptake is higher. That is designing through an equity lens. And that's what's often missing in many of our public health programs. So yes, will it require more money? Perhaps. Will it require a difference in how we use the available resources? Definitely. And that's where I think there are early signals on what we can do here as we approach this new technology. But don't think that inequalities are a natural order and they have to happen. We have great examples where with proper design, you can actually avoid those inequalities worsening. So thanks.
My brother's got the microphone at the moment. Professor Mike Kirby.
Thank you very much. The lecture was fantastic. Thank you very much.
Thank you.
But, you know, we've had some wonderful information interrogating databases. But it's only as valuable as the quality of the data within, and that's often where bias comes in. I mean, is there any plan to make sure that we are recording data in the same way in primary care, in secondary care, in public health, so we really can interrogate it and rely on the quality of the data when we decide to interrogate it?
Yeah. So Mike, I couldn't agree with you more. And I wish I could say, yes, there's a big national plan, and yes, things are moving in the right direction. Many of you know that in my own work and research on looking at health inequalities, even collecting information on a patient's race and ethnicity has been one of the most challenging things we've had to do, let alone getting more information on your employment, your area of residence, and so forth. Thankfully, Mike, the movement towards population health management within the NHS has really, I think, been helping to stimulate and revolutionize how we collect data and interrogate the data much more effectively. the introduction of electronic health records, the reduction in the variety of EHR systems that we have across the country, and the use of new AI tools to help us to extract data and combine data. I'm beginning to see, and I'm hopeful that in the population health management space and using better NHS data and having access to the data, we'll see things improve. In the data that I get to look at for London, we're now having a much richer data set that I think is providing us with much greater insights into population health. And that, I think, is enabling us to understand where the gaps are and where we need to work with our providers to get more timely data, higher quality data, et cetera. And we're applying quality improvement methods with our provider trusts and units to help us to say, actually, the quality of the data that we're getting is not as great. Can you help us? Let's work on an improvement program. So it's not going to happen overnight, but I think there are a number of concurrent movements which are occurring, which may well help us to get better quality data over time. But I couldn't agree with you more. In Epidemiology 101, rubbish in is rubbish out when it comes to data, and you have to invest in data systems. Now, the other idea that we have to look at is what I mentioned, what the CDC and others are doing, which is looking at a variety of other data sources and how we are able to combine them to truly get a picture of health and determinants. So whether it's looking at, and I wouldn't say the newspapers and the media, but whether you're looking at data on weather patterns in London, air pollution and air quality patterns, to begin to do predictive analyses for when to tell people to take their nebulizers or to be careful about asthma attacks and so forth. So we're able to look at things differently, and population health management should help us to do better with NHS data.
There's great interrogation here. The gentleman with the dark shirt, tell us who you are, and then the question, then I think last question, the lady at the back there in the darkness, so sir.
Thank you. David Francis. I'm a director in local government working across 7 local authorities in West London. That involves working closely with NHS colleagues across the ICS. It was a great lecture, Kevin, and it's good to see everything brought together in one space, because I've seen previous presentations where it's been quite chunked up, so you covered a lot of ground. And my question is about leadership, which is where you finished on, and in particular, place-based leadership, because the inequalities that you've talked about, the indexes of multiple deprivation, they're often, they're quite localised. And during the pandemic, the role of directors of public health really came to the fore. And I think most of us in the room will know that public health has moved from the NHS into local government. You wear a number of hats across London. It's quite a complex kind of organisations. It's hard to know, which bit's doing what. So my question really is, you've identified that leadership's important. How do you see the ICSs as a way of bringing that leadership to do what we want? And how do you think that's working and what needs to change?
So I started the lecture by describing the complexity of the systems that we have at the moment. And one of the things that I keep encouraging people to do is to stop trying to find solutions within one partner or one system. Because actually, in a complex, dynamic, and evolving system that we have, which is our health and care system, you need every player to do their part synergistically to get a better outcome. So whereas the ICSs and the ICPs, as you think about local government working with the NHS, will have a role to play, actually that leadership is also in local businesses, it's in local academic institutions, it's in the different players within place, which can help us to think about how we work together with this new ecosystem that's being created. In the same way that dealing with the climate crisis isn't the responsibility of any one organization, but we need every organization to play its part in order to get to a different place. Now, public health practitioners, I think, using the example of climate change, and I'm really glad to see my colleague Dagmar Zune in the room, who's been a stalwart in leadership of public health directors for climate change and health, that journey requires both educating ourselves, educating our partners, having a strategic approach to intervention and building capacity, and acting concertedly with the public, with leaders, with councillors, everybody. And I think that is needed. Now, for the Faculty of Public Health, just to say, so you know that I'm walking the walk and talking the talk, right? Because that's really important. We have established a Future of Public Health program where we're interrogating how AI, commercial determinants of health, social cohesion, place shaping, all of those things are going to have an impact on public health. And we're already beginning now to set up the policy teams to begin thinking about what does public health practice look like in 2040, 50 and beyond. We've established an AI and digital health special interest group. So we're getting all public health practitioners who are interested in this space to skill up, to build their capacities and capabilities so that they can become effective advocates in the field. And we're wanting to look at who's doing great work in place, so that we can begin to think about the needs which are there and how we can help to improve that as well. So that visible, courageous leadership, but it's part of being the system. So it's not just one organization, but everybody acting together. So hopefully that helps, but in a complex environment, get beyond. We must get beyond any one partner holding the ring on this.
Very last question from the back there.
Thank you. It was a fantastic talk, and thank you for the overview in such a complex area. So I'm a physician and NHS consultant, not in public health. I'm Roger Kirby's old house officer from many moons ago.
She's a brilliant house officer, she was.
So I wanted to bring it back to inequalities. Of course, as you've said, and many people have said, it's only as good as the data that's input. Mm-hmm. And so if we look at skin, for instance, currently, there is very little skin of colour in all the many AI apps that are around. Mm-hmm. So how do our patients or the general public know about its shortcomings and know that it's not going to be able to give them as good a diagnosis as someone with white skin, where there is more data input into the current AI apps?
Mm-hmm. So that's a really good example, because we've been doing work with a couple of companies that are in this space. And they have recognized that their product will be deficient if they're not building their product for diverse communities. And so they have an active program of, especially in dermatology, ensuring that they're building the databases, encouraging and working with communities, training clinicians as well, and thinking about diversity, and using the same principles that I mentioned to Jill earlier, which is thinking about equity at the beginning of the process, and then being able to extract, develop your databases and so forth, so you're building it for all populations. So I think that's, paradoxically, the example that you've given is one of the areas where I personally know that there's a lot of really good work here and developers who are beginning to think through how do you build tools for diverse populations. Now, as leaders, we have a role to play in both stimulating the market and holding the market to account. So I'm hoping that as we develop strategies on AI, regulatory frameworks, I know I and others will be asking about the equity dimensions for that regulation and those frameworks, and to ensure that we are clear, crystal clear, in saying what is required for us to have technologies which serve all members of our communities. So thank you. A great question to end on. Thank you.
Well, well done, and thank you so much, Kevin. I'm going to present to you now the 73rd Stevens Medal, which you can proudly present in your room. I made a mistake. I said, how does one of Edward's children? Of course, he's a grandchild. David, Lord Stevens, should be here this evening, but he's been delayed, might join us for supper. Thank you so much to the Stevens family. David has actually made a donation to the RSM for our gene therapy meeting, which Jill is leading on the 11th of July. So if you're interested in gene therapy, another amazing, innovative area of medicine, then do come along. But I think a round of applause for Kevin. Done a brilliant job. Kevin CBE.
Thank you so much.
Congratulations. Thank you for interrogating our speaker so well that you can grill him some more next door in the atrium where we'll have some drinks. Thank you very much, everybody, and thanks for joining us. Thank you, Kevin.